We already arrived in the area of gallbladder carcinoma, touching upon the T1As and T1Bs. And the next speaker will elaborate on gallbladder carcinoma. Christos Dervenis, the president of the E-AHPBA from Athens, will discuss with you surgery for gallbladder carcinoma. Christos, please.
Thank you, Thomas. I would like to thank you both that you asked questions from my talk to the previous lecturer. So it's a relief. Thank you very much for asking this question to the polyps issue. So I would like to thank the organizers. It's needless to say that I feel home, and I have a personal record that I see that is the 13th Congress of the HPBA Association in Turkey, and I've been here in the 7 out of 13. So the only person that could challenge this record is Thomas Van Gulik, which is, I don't know how many congresses of the HPBA Association you are here, Thomas. So I would like to thank you, and I should say that I have been impressed as always by the quality of this postgraduate course. So my task for today is to discuss with you the gallbladder cancer, which is the 5th most common neoplasm of the digestive tract. The incidence, at least in the United States, is 2.5 per 100,000 people. There is, it's associated with a poor survival. There is no really effective therapy except surgery. And for this reason, complete resection is the only potentially curative option. There is 3 ways that gallbladder cancer presented in a patient has been presented either as a mass at the gallbladder, which is discovered at operation, a mass discovered at operation, or in the form of the so-called incidental, which means that it's diagnosed at pathology for gallbladders operated upon for benign reasons like cholelithiasis. There are some risk factors for gallbladder cancer, which is not proof that is a real risk factor, but has been accused, let's say, for gallbladder cancer. It's cholelithiasis, the cholecystitis fistula, infection, 44 bacillus, anomalous pancreatibiliary junction, adenoma to carcinoma sequence, as we have already, and adenomatous polyps. Why surgery for gallbladder cancer? As I said, this is the only option to deal with this kind of disease, and because with surgery it's only possible to complete surgical removal, which offers only chance for improving survival. Although there is a positive randomized control trials and any prospective data, the most of the published series are the retrospective series. So the clinical decision making is largely based on retrospective data. Experience from high volume centers are always welcome, and this experience tell us that there is an improvement in outcomes with acceptable morbidities if the gallbladder carcinoma surgery is performed in high-volume experience centers. This slide is showing us what is all about the gallbladder cancer, and shows us the different levels of infiltration through the gallbladder wall. And as Thomas pointed out, this is the most important issue, and this issue has been addressed in different TNM editions, started from the 5th one to 6th, which is changes our concept in the T stage or the N stage. And I would like to go directly to the last edition of TNM, who pays attention to the definition of T2 categories and N categories, and this the main difference from the previous editions of TNM is that the T2 tumors now is not all the same. It was obvious, but it has not received a proper attention in the past because there is a very important issue: where exactly is the tumor? Is on the liver bed side or on the peritoneal side? So because the prognosis is different, and probably our surgical technique should be different. Now, in the 8th edition, as I said, we have the T2A when the tumor invades the perimuscular connective tissue on the peritoneal side with no extension to serosa. On the contrary, the T2B is tumor when the tumor invades the perimuscular connective tissue on the hepatic side with no extension to the liver. So probably these two different categories of patients with T2 disease should be received different kind of operation. But we don't know what probably could be. The other difference is that with the 8th edition, TNM edition, is the different staging of the lymph node status, and now we come back to the numbers instead of locations. And now we have the N1 disease when we found metastasis to 1 to 3 regional lymph nodes, and N2 when we found metastasis to 4 or more regional lymph nodes. And of course, in order to be on the safe side, patients should be receive resection on lymph nodes, and we should resect more than 6 lymph nodes in order to have an accurate N staging. Staging is very important because it's different prognosis, and probably, as I said, the patient should receive different kind of surgery. And with the patients, if the patient has a T1 tumor, then complete cure is possible. The problem with this is only 1 out of 10 patients have this category of cancer, and the disease-specific survival is almost 100%. In that case, simple cholecystectomy is in the most case sufficient. Now with PT1B, this is a controversial issue, and especially concerning the extension of surgery. And the question is simple cholecystectomy sufficient, or we should go for radical cholecystectomy? Although the NCCN recommends radical surgery in PT1B cases. Now with PT2 stage, the radical cholecystectomy is the treatment of choice, as we have a long-term survival. The problem with this is when we dealing with the gallbladder cancer is we don't know exactly before surgery the stage of the disease. And with PT3 and to PT4, we have poor outcomes. But even with PT3, I think cancers, I think that the patient should receive surgery and block resection, and in some patients could be of their benefit. With PT4, generally cancer is generally not resectable. There are some contraindications for surgery for gallbladder cancer. It's of course the metastatic disease, the involvement of the portal vein and the hepatic artery. The left portal pedicle involvement is a disease-related contraindication, the direct involvement of more than 2 adjacent organs, and of course the inadequate FLR, which if the major hepatectomy is planned. And of course there are some patient-related contraindications such as poor performance and medical and fee due to severe comorbidities. The rationale for radical surgeries in gallbladder cancer is the modality of spread, and we know that there's different modalities of spread in pancreas of cancer cells as through the lymphatics. So we should pay attention to lymph node clearance, vascular through the venous, especially through the venous drainage. And there are some other such way of spreading, such intraperitoneal, neural, intraductal, and direct extension within the parenchyma around the liver bed. So we would like to describe the extent of resection of gallbladder cancer is cholecystectomy. If not previously performed, this is referred to non-incidental gallbladder cancer. Is the wedge resection of the liver or the resection of the segments 4B and 5, and even sometimes extended right hepatectomy is needed. Lymphadenectomy should be included the periportal and lymph nodes, the cystic, the retroduodenal, and retropancreatic. The extrapancreatic bile duct excision with hepatic angiogenostomy is not routinely performed at its, and of course it should be used in selective cases. This is a standard practice when we do the lymphadenectomy with a wedge resection of the liver, and we should be very meticulous in clearance the hepatojejunal ligament and the right hilar plate dissection. The specimen should, the area of the clearance should be like this. In the question which is better, if the liver wedge resection is better or the extended resection, liver resection is better, with the wedge resection we have some potential advantages, which is together with the effectiveness of oncological resection is technically easy with low morbidity, but still there are some disadvantages because it is inadequate resection in the presence of more distant satellite nodules, and there carries the risk of incomplete resection. The other option, the resection of the segment 4B and 5, have again some advantages. It's more adequate oncological resection. Probably it's more adequate oncological resection is the traditional recommended procedure, but it carries increased risk of complication and mortality, and the survival benefit is questionable. We have some trials from the literature, which are retrospective studies, as I said, comparing the wedge resection with the liver resection of the 4B and 5. And the authors here, this is a study from Japan, they find no difference in survival or recurrence, and at the same time the complications were higher comparing to wedge resection. Other surgical consideration in the question if it's a staging laparoscopy before the resection is mandatory, and there are some studies saying that they may change the management of the patient in 1 or 2 out of in 30 to 50% of patients. Lymphadenectomy, as I said, now we should resect a minimum 6 nodes in order to stage and to improve, to offer to survival of the patients. But the role of the more extended lymphadenectomy is debatable, is the same the discussion as the pancreas cancer. And some patients should advise routine sampling of the arteriocaval nodes to rule out metastatic disease. Again, is the same question with the pancreas cancer, if we should sampling routinely the arteriocaval nodes. Bile duct resection, of course, it's a selective indication. There is no survival benefits, but sometimes can offer to contribute to the R0 resection. What about the major hepatic and multivisceral resection? There is no standard surgical practice, and in the most of the cases, morbidity overweights survival benefit. I will skip this because it's a summary of what we said. So the principles of surgery in gallbladder cancer, which have been diagnosed preoperatively, should include cholecystectomy with unblocked hepatic resection of the liver bed, or in some cases of the segments 4B and 5, with or without bile duct excision, and of course the meticulous lymphadenectomy of the porta hepatis and gastroduodenal ligament. There are some prognostic factors that should be taken into consideration, which is tumor-related, host-related, and environmental-related. And now there is none of them has been proved, that is, except the R0 resection, that is very critical in prognostic, as a prognostic factor in gallbladder cancer surgery. But there are some new and promising biological indices like the FGFR2 mutation, and probably, but it's not in clinical, everyday clinical use. So based on this would be thinking about to use some systemic therapy for gallbladder cancer. There are some papers in the literature recently dealing with this issue, and the ESMO decided that the adjuvant treatment should be used, and especially a combination of cisplatin and gemcitabine, and or other gemcitabine-based combination should be used as an adjuvant treatment. And in the latest guidelines from since 2016, they included, as you can see on your left side column, that the adjuvant chemotherapy it's mandatory after surgery in biliary tract cancer and in gallbladder cancer. This is the same guideline. Now I would like to come into the so-called the incidental gallbladder cancer, which is defined as the tumor discovered on histopathological examination following cholecystectomy for benign disease. What's happened? Okay. So in the last decade, the frequency has increased significantly, and it might be related to the surgical community's lower threshold for cholecystectomy for benign gallbladders in the for benign gallbladder disease in the laparoscopic era now, meaning that more gallbladders is resected now because of the laparoscopy, and more incidental cancers should be diagnosed. The incidence of the incidental gallbladder cancer is something between 0.3 to 1%, and the diagnosis of incidental gallbladder cancer far outnumbers the clinical diagnosis of non-incidental gallbladders. Now we are discovering incidental gallbladder cancer more often than the gallbladder cancer preoperatively. In general, we know, because the question is, okay, we found an incidental cancer, the pathology came and say we have an incidental cancer, and then what we should do. Now we definitely know that the patients who received a reoperation after the incidental gallbladder cancer lives longer, comparing with the patient who does not receive any kind of resection. The problem is how we select the patients now based on the pathology report. How we can do that? With TT1A, the possibility to have a lymph node infiltration of infiltration of the lymphovascular or perinuclear tissues was not found. So repeat surgery with resection of the gallbladder fossa is unnecessary, as it does not provide any clinical benefit. On the contrary, with the patient with who has the T1B, now the incidence of residual disease in the gallbladder fossa and the lymph nodes increasing by 10%. So that means that this in most of the patients with T1B disease, because of the potential aggressive natural history of gallbladder cancer, the resection is justified. The role of the lymph node dissection in the treatment of gallbladder carcinoma in this patient, in patient with the T2 disease is 62%, meaning that in more than half of the patients of the patient who had the T2 disease has at the same time infiltration of the lymph nodes. So if the patient with T1B should receive surgery, I think that, of course, the logical thing is that the patients with T2, which carries much higher risk of local regional recurrence, should be received a reoperation. And this is a diagram from the Memorial Hospital that we can see there that the patients who received radical resection comparing with simple cholecystectomy in T2 tumors have a very significant survival benefit. So the data so far strongly suggests that aggressive resection is needed, as the majority of patients with the T2 tumors will have residual disease, and with the repeated surgery we can offer a local lesion control and survival benefit. Now, why T2A and T2B? As we said, this is a differences now, and there is as I said, there is a strong predictor of tumor progression and survival in two cancer related to where and which surface of the and which side of the gallbladder the cancer is located. But I don't think that now we can, although we know there is a worse prognosis if the tumor is on the hepatic side, we don't know what we can do differently so far. I think, and I believe that in the future, the patient should be classified according to the side of the tumor when they have a T2 tumor, and then we should act accordingly. T3 tumors, which is, I should say, not very often incidentally discovered, but there is no way that this patient need re-resection, and if they received an appropriate re-resection, they can have a 5-year survival and something between 25 and 60%. Now the question is how we can work up the patients preoperatively when we decided to reoperate in the patient with incidental cancer. I think that CT or MRI is helpful in identifying metastatic disease, but the PET-CT is questionable, and although there are some reports that the PET-CT could lead to changing of the management of the patient in 1 out of 4 patients, I don't think that is in any center. If you agree with this, that they use the PET-CT scan as a routine in the patients who should plan to receive a reoperation. So this is an algorithm for evaluation and management of the gallbladder cancer, and you can see here that PET-CT is an algorithm, but as I said, I don't know if any uses as a routine the PET-CT. We don't. Finally, how extent should be our surgery, and the elements of the operation is, of course, the resection of the liver, the local regional lymphadenectomy, and questionable if we should resect the port sides, because most of the patients have received the laparoscopic cholecystectomy, and what about the bile ducts? Concerning the liver, there is 2 types of tumor spread into the liver. There is a liver bed type and the hepatic hilum type, which is the tumor is spread along the Glisonian sheaths of the ducts after involving the hepatic hilum, and the argument against the wedge resection in that case is that it's very difficult to have a clear resection margins if the tumor localized to the neck and the body of the gallbladder. So the extent of the liver resection have been tested in different, although retrospective studies, and they do not find any advantage of the extended liver resections comparing with the wedge resection if we receive the R0 resectable surgical resection margins. So I suggest that we should look at the margins instead of looking at the extended surgery. And I like to quote this from the editorial published some years ago from the guys in Johns Hopkins, that they stated rather than a routine extended resection, a more rational approach is to consider the extent and location of the tumor and to plan the extent of surgery to achieve microscopically negative margins. Lymph nodes, again, as I said, I don't want to, in the interest of time, to repeat. Lymphadenectomy should usually confine to the portal and to hepatoduodenal ligament area, and extended radical resection is not routinely advocated. Surgery for the bile ducts, there is some pros and cons of the inclusion of the bile ducts, but I should say that despite the fact that sometimes resection of the bile ducts facilitates lymphadenectomy and improves control, the studies showed that there is no improvement in survival, so I think that resection of the bile ducts should be on demand instead of routine use of the resection of the bile ducts, especially with frozen section of the cystic ducts is positive. I would like to go into the final conclusions. Patients with the T1B, T2, and T3 incidental gallbladder tumor should be offered an additional oncologic surgery. Prior to reoperation and CT scan should be obtained. PET-CT, it might be helpful in a complementary manner. The extent of surgery should be guided by the disease degree with the principal aim of negative margins, and in T2, the extent of tumors, the extent of resection and necessity of adjuvant therapy should be determined according to the likelihood of microscopic liver metastasis or nodal involvement in individual patients. And I would like to say that this, together with this very interesting postgraduate course, this is the second postgraduate course in Athens next week. And although it's a very little bit late for your information, where all of you are welcome in Athens next week to listen to this postgraduate course on pancreatic cancer. Thank you very much.